Hello everybody. I'd like to thank the organisers of this event for inviting me down to speak on behalf of CouNTDown. I think Ross was scheduled but he couldn't make it, so I'll do my best to fly the flag for him on his behalf. So I work within CouNTDown, which is a multidisciplinary consortium based at LSTM, but it actually works across 4 African countries: Nigeria, Liberia, Cameroon, and Ghana. And these are kind of classified at different stages of controlling and eradicating particular NTDs. The entity of interest for me is Schistosomiasis. So Ghana is placed closer to possibility of eradication than some of the others due to its infrastructure and its health service as well. There are 5 main themes within CouNTDown. There's evidence synthesis, applied social science, health economics, as well as integrated complementary strategy theme 1, or ICST, ICST 1 and ICST 2. So these 2 are more field-based and are more heavily parasitological and vector targeted, whereas the others, we've got a social science, health economic, and evidence synthesis. These are more qualitative, maybe a little less quantitative. But across CouNTDown, we're trying to bring together all these different disciplines to more efficiently target and control the NTDs here, the microfluoricides, schistosomiasis, and STH as well. So I work within the schistosomiasis project and in Ghana, and my particular specialty is molecular diagnostics. So what is it that we're doing in Ghana? So our main aim is to see if expanded access to treatment, to praziquantel and albendazole, would be more beneficial to a community than the current approach, which is just to treat school-aged children generally who are attending school. So this approach means that we're actually targeting a wider number of people who are also infected, whereas the current strategy, just targeting the school-aged children, ignores adults, preschool-aged children, but also school-aged children as well. So we're hoping this approach might lead to better control of the disease. We're targeting 3 communities in peri-urban areas around the Ouija Reservoir within the Greater Accra region. And these are Tomofa, Adakope, Tokokope, and Mahen. We've run a parasitological baseline survey as well as an epidemiological survey which has WASH indicators included in the questionnaires, and there's lots of pictures of different types of toilets and latrines and that side of it. And in the parasitological survey we did Cato cats, urine filtration, microhematuria, dip sticking, and we then took about 15% of these samples back to LSTM and ran a qPCR analysis of the samples for a quality control to compare this with the findings of the more traditional parasitological data. And the idea is that we'll treat the whole community. So we've sampled about 650 people per community, and each community is around 1,500 to 2,000 people. And these will all receive treatment, barring women in the first trimester of pregnancy and very young children as well.
Can I ask a quick question? Yes. Did you put in the WASH, or was that already there?
So within this project, we're not carrying out any WASH activities. We're just observing WASH what's there, yeah. So I think the ideal would have been to include WASH intervention as well, but due to the design of the study, we couldn't incorporate that. But what we will do is we'll then go back every 6 months, doing a baseline, doing further parasitological surveying to see what effects as the community-wide treatment had on these 3 particular communities. So what is it that is needed to support chemotherapy, and what are the disadvantages of MDA? So MDA is touted as the way to, or is currently being used to control schistosomiasis. However, you don't often get complete coverage. Vulnerable groups are left out in the current strategy, just targeting school-aged children. Praziquantel is only effective for adult worms, so if the individual has juvenile worms or eggs in them, that won't affect them. The juveniles will develop into adults. The treatment doesn't always clear all the adult worms. There's also issues of infection, so you're just treating a small section of the community, but then if they're cleared, that's great. Then they go back to the homes, they interact with the community, they bathe and wash, and they get reinfected. And in cases where we've got some communities with 90% prevalence, this reinfection rate is very high. And you can also have quite a few adverse events. In some of the literature I've read, it could be between 25 to 70% adverse events recorded. And there's a range of adverse events, but these are adverse events nonetheless. And this can put communities off from accepting further MDA programs. And this is true in communities where there's very high prevalence and intensity of infection, where the adverse events are more severe, but also in communities where the control has been successful and it's been driven down to, say, 3%, and the community might not want to have to keep taking these drugs, which they no longer see as beneficial to them. So they'll reject the MDA, and then in maybe 5 to 6 years, the prevalence of schistosomiasis has come up again. So there's the issue of compliance, long-term compliance with MDA, and the effects adverse events have on this. So with WASH, which unfortunately we're not able to include in our study, but WASH may be able to mitigate some of these weaknesses within the MDA model, as it deals with both the exposure and contamination sides of the disease. And if you affect behaviour, it has the potential for a more longer term effect, whereas MDA, you'll get reinfection fairly quickly and you need to maintain this. Whereas if you can change the behaviour and the culture of a community, this could persist for some time. If you look at aspects of our culture which are very ancient, which have existed for a huge amount of time, this lends credence to the idea that cultural change can be very persistent. However, it requires a considerable investment in time and money. It's also hard to monitor its effects. Do you have self-reporting, in which case there could be bias, or are you constantly observing people, in which case their behaviour may be altered because they feel they're being observed and they won't behave as they naturally would. And it also doesn't necessarily deal with the spread of schisto from the movement of people. If it's just dealing with interactions with water and hygiene, you could get a group of people moving to another area of the country or another environment where the snail is present, and then you'll get the continuation of the disease just in another area. And just lastly, just to mention, there's a very good paper that's published recently from a colleague, Susie Campbell, who's working within CouNTDown, talking about the role of WASH within the control of schisto.